Immunology of Inflammation. These are the learning objectives. By the end of this lecture, you should be able to describe the processes of initiation and resolution of inflammation. Of course, we'll describe what inflammation is. You should be able to describe the phases of inflammation. You should be able to outline the mediators of inflammation and then describe the types of inflammation. We won't really go into so much detail on the types because you'll go through that again in pathology in third year. So this is what inflammation is. It's a reaction of living tissue to injury of infection. So it's important to know that it has to occur in living tissue. So it's in a host who is alive. In a cadaver, you cannot get inflammation, okay? And usually it's a protective response to what would be perceived by the body as a danger signal. So this danger signal could either be an infection, so presence of microbes or pathogens. It could be trauma, whether it's a blunt force trauma or whether it's trauma that involves cuts and things like that. It could be to ischemia, where there's reduction in blood supply to a certain part of the body, meaning there's reduction in delivery of oxygen and nutrients. It could be physical injury, it could be chemical injury, okay? So what happens when you get any of those things occurring, if it's a pathogen, of course, what will be recognized by the host immune system, usually the innate immune cells, would be the pathogen-associated molecular patterns. When you have cell injury, there's some changes that occur in these cells that leads to formation of what we call damage-associated molecular patterns. So those that is what will be recognized by the innate immune cells. That's the monocytes and the macrophages, as well as the dendritic cells, and will lead to their activation. And remember, these are the cells that will bridge the innate immune response to the adaptive immune response. So when you do have activation of the cells of the monocyte macrophage lineage, this results in expression of pro-inflammatory genes, okay, in different kinds of cells. And when those genes are expressed, of course, the end product will be production of the mediators of inflammation and activation of immune cells that will participate in this inflammatory response. And then you also get suppression of anti-inflammatory genes. Usually in a normal host, there's homeostasis, so there's a balance, okay? To the cellular level, the inflammatory reaction involves mainly the blood vessels and white blood cells. So you get certain changes in the blood vessels, and we'll describe these changes, which allow basically for the passage of white blood cells from the circulation to the site or to the tissue where this process is taking place or where the injury has occurred. Remember, apart from the macrophages and the dendritic cells, the other white blood cells, the monocytes, the lymphocytes, usually just circulate in blood. For the lymphocytes, they'll also traffic through the lymphoid organs, but majorly they'll be found in blood. So for them to leave blood and come to the site in the tissue where there's cell injury or cell death, there have to be changes in the blood vessels that will occur, and that's part of the inflammatory reaction. There are certain mediators or molecules that are involved in recruiting these white blood cells and causing the changes in the blood vessels. So this includes cytokines, chemokines, and other chemicals, which we're going to mention. And then we also have other molecules that are involved, for example, plasma proteins, and then I've mentioned the white blood cells and the tissue phagocytes. So these are all the players of the inflammatory response, and this picture basically just summarizes what I'm talking about. Trying to get the laser pointer. Okay, so either you get damage to epithelial cells, for example, or you get pathogen entry. Remember, microbes usually would have to attach onto whichever epithelium it is, depending on the site of infection. It could be mucosal, it could be the skin, and so forth, before they can now actually multiply and cause tissue damage. So those will be recognized usually by the resident macrophages or the dendritic cells that are found within that tissue, and this will become activated and produce different molecules, for example, cytokines, that will have an effect on, you can see now down here, we have the blood, the closest blood vessel to that particular site. So these different cytokines and chemical mediators will cause changes in the vasculature such that you have some sort of separation between the endothelial cells, which will allow for white blood cells to traffic out of the blood vessel and to the sites. Usually this would be the monocytes and the neutrophils if it's an acute inflammatory process. When it's prolonged, then you do get your lymphoid cells also now trafficking to the sites. And remember, the phagocytes, which are the neutrophils and monocytes and macrophages, usually would phagocytose and basically kill whatever pathogens that are there, okay, through your oxygen-dependent and independent mechanisms, but they're also involved in activating the cells of the adaptive immune response, basically the lymphoid cells, through antigen presentation, okay? The other thing that happens, remember we talked about plasma proteins also being involved during an inflammatory process. Some of the cytokines that are produced by the macrophages will have effects on different organs. So for example, there's some effect on the liver to produce certain proteins that are involved in this inflammatory response, and we usually use them as a marker in the clinical setting as markers of acute inflammation. They're called the acute pace proteins. You'll cover more of this in clinical chemistry in third year. So they include proteins like alpha-1 antitrypsin, the C-reactive protein, and ferritin, okay? And I'm sure if you see this, if you've been reading around or keen to know more about the severe inflammatory response or the cytokine storm in severe COVID-19 disease, you've seen them talk about interleukin-6, tumor necrosis factor, and interleukin-1 as the primary drivers of this inflammatory response. These are cytokines of the innate immune system that are produced mainly by the macrophages and dendritic cells. And you've seen that in some of these patients, if they want to like predict, they use certain biomarkers to predict severe disease. So this includes like serum ferritin and C-reactive protein. These same cytokines also have an effect on the hypothalamus, where they cause certain changes that would now be responsible for the symptoms the patient has. For example, increasing the setting of the basal temperature. Thus, a patient will present with fever, causing somnolence, anorexia, and pain, okay? Which usually would be some of the symptoms a patient presents with for us to know that there's something going on. It could be infective, it could be something else. Our complement system is also involved through the complement proteins. Remember, I think you've already covered the complement system, and we've seen some of the byproducts like C3A and C5A that are anaphylatoxins or are involved in the inflammatory response. So they also cause some of these changes in the vasculature and recruitment of cells, of white blood cells from the vasculature into the site of damage or the site of infection. So usually there's an amplification of these vascular and cellular reactions, and this depends on the severity, the type of pathogen, and things like that. So of course, for example, the higher the burden of pathogen, the more magnified this response will be, and things like that, okay? And as I alluded to, inflammation can be acute or chronic, depending on the nature of the stimulus. So you later come to see in third year that when it comes to pathogens like bacteria, for example, the extracellular bacteria usually would, or those that cause extracellular infection, will induce an acute inflammatory response. Those that cause which are most of the bacteria, and then those that cause an intracellular infection, for example, Mycobacterium tuberculosis, will induce a chronic inflammatory response. One, because they tend to persist. Remember, your pathogens also have ways of evading the immune response. So when they evade the immune response, then they'll persist for longer, and an acute inflammatory response really will not be able to get rid of the pathogen. So they tend to induce a chronic inflammatory response, and we'll see the differences between these two. The second thing would be the persistence of the pathogen. If the acute inflammatory response is able to get rid of the pathogen, or whatever induced that response, then it's going to resolve. If you're not able to get rid of the inducing reaction, whether it's a pathogen or any other type of damage, then the response will persist and then transit into a chronic inflammatory response. In terms of the differences between an acute and chronic inflammatory response, or actually the features of these types of responses, for acute inflammation, usually this is rapid in onset. Remember, we've talked about the innate immune system always being present and ready. So once there's the damage or entry of the pathogen, then these cells that will be involved are already present. For example, your macrophages within the tissues. So onset of this type of inflammation is rapid. Usually it takes minutes, but it lasts for a short time. So it's of a short duration. The primary or major cells that are involved are the neutrophils. And remember, we said that neutrophils usually have a very short half-life. So once they come into the tissues, they do their job, which is primarily phagocytosis. If they're not able to engulf or the pathogen, for example, or if the phagocytosis is frustrated, then they release the intracellular contents. And of course, that leads to cell death. But even if they do take place in the phagocytosis effectively, usually their half-life is about 4 to 6 hours. So the ones that come into the tissues would die within that amount of time. The main characteristics of acute inflammation would be, remember we talked about plasma proteins also being involved. So the plasma proteins are also found, they're found in blood, okay? In the liquid component. Remember, blood has two components, the cellular and the liquid component. So if you take out the cells, then you have plasma, okay? If you allow the blood to clot, the liquid component that remains is serum. So the difference between plasma and serum is that the serum does not have the coagulation proteins, okay? Which are also plasma proteins, okay? So this plasma would also, in an acute inflammatory response, would also exudate out of the vasculature. So as the cells are coming out of the vasculature into the tissues, you also get leakage of these plasma proteins, and they come to the site. And when they accumulate at the site, they cause tissue swelling, which medically we term as edema, okay? And I've talked about the fact that the major cells that emigrate are the neutrophils. So usually, if this acute inflammatory process is successful in eliminating the offender, then the reaction will subside. If it is not successful, then it can progress to a chronic inflammatory response. So chronic inflammation may either follow acute inflammation if the acute inflammation is not successful, or it can be insidious in onset. Remember, I mentioned that there are certain types of pathogens or antigens that would ultimately just induce a chronic inflammatory response. Like it doesn't start with an acute inflammatory response and then progress. So this would be longer duration. In terms of duration, when like a patient presents with signs of inflammation, usually if that history has been less than 2 weeks, then it would ultimately be an acute inflammatory response. If it's of a longer duration, more than 2 weeks, then we usually just say it's a chronic inflammatory response. The major cells that are involved are now the lymphocytes and the macrophages, what we call the mononuclear cells. And this is in reference to the nuclei of these cells. And well, we pathologists like to use this when we are evaluating, for example, tissue biopsies where there's an inflammatory process. If we see if we say that we're seeing mononuclear cells, usually we refer to lymphocytes and macrophages. Of course, if they're neutrophils, then there'd be polymorphonuclear cells, because remember that alludes to the morphology of the nuclei of neutrophils. Remember, these usually have 3 to 5 lobes, okay? The blood vessels are also involved, and in chronic inflammation, you get proliferation of blood vessels, so there's an increased vascular response. The other thing that happens in chronic inflammation, and you'll cover more of this in pathology, is that there is damage that has induced the inflammatory response. So one, there's attempt to get rid of, for example, that pathogen or the offending agent. There's also attempts at healing, okay? However, with chronic inflammation, sometimes because of the tissue destruction that is there, the healing may be sort of frustrated, like you may not get, so healing would mean that you're taking that tissue back to its normal morphology, but sometimes if you get so much damage to certain types of cells and they cannot regenerate, then instead of regenerating, you get laying down of collagen, okay? So that is what we call fibrosis. So usually we tend to see fibrosis with a chronic inflammatory response. So as I mentioned, there's always homeostasis in the body. So whenever there's an inducing agent of inflammation, usually once that offending agent has been cleared, then the inflammatory response is supposed to be terminated. Okay, so I talked about once your monocytes or macrophage system has been activated, or those cells have been activated, you get production or you get your pro-inflammatory genes being activated, then you get your pro-inflammatory signals. For example, the genes that code for the cytokines that are involved in the pro-inflammatory response are the ones that are going to be activated so that these proteins are produced. When this is terminated, when the offending agent has been removed, then you get the anti-inflammatory signals being the ones that are activated. So you need something to silence the pro-inflammatory response so that the tissue can go back to normal. So the things that occur to just ensure resolution of the inflammatory response occur because, one, the mediators that are involved, like the cytokines, the chemokines, the plasma proteins, usually are broken down and dissipated. So when they're broken down, they're no longer going to be active. I talked about the neutrophils in acute inflammation having very short half-lives or lifespans. So they also die off and they can't continue mediating the response. And I've talked about anti-inflammatory mechanisms being activated. And the thing to remember is that acute inflammation is, inflammation is mainly acute inflammation. It's majorly an innate immune response. And remember, one of the differences between the innate and adaptive immune response is recognition. So as much as and specificity. So as much as this macrophages, for example, can recognize dumps and pumps, when they now release the mediators that cause cell injury or cellular killing, these mediators are not going to be able to differentiate host tissue from a pathogen, okay? So for example, when the neutrophils release their nets, and the contents of their granules. This, like for example, the enzymes that are found within the lysosomal granules will damage both the pathogen and the neighboring cells, the normal host cells. So if we cannot control this inflammatory response, then it means we'll get excessive damage to the host themselves. So this is just to reiterate the importance of inflammation. Without inflammation, infections would go unchecked because, of course, now it means you're not even activating your innate immune response. So the pathogens would just thrive, and we'll later come to see in fourth year some of the immune deficiency disorders, the ones that are genetic in origin or the primary immune deficiencies, which involve cells, the innate immune cells, and we'll see how these patients now tend to present with persistent infections. And most of these primary immune deficiencies without curative intervention usually would limit someone's lifespan. I've talked about chronic inflammation being important in leading to healing. So without inflammation, wounds would never heal, okay? If you get a cut, like if you accidentally cut or prick yourself, you always see some redness, some swelling, some pain, okay? All that is part of the inflammatory response that will, even if, like, for example, that cut is not, whatever cut is not contaminated, you still get the inflammatory response because there's damage, okay? And that is important too, to cause healing, okay? So without inflammation, there would never be healing, and you'll go through healing and repair in third year. And then the other thing is that injured tissues might remain permanent festering sores because, of course, there's no healing, okay? So the ideal inflammatory response is rapid and destructive when necessary. Ideally, it should only destroy what is offensive, but ideally it should be specific and self-limiting, okay? So there's a group of pathologies where there's uncontrolled activation of the inflammatory response, okay? And in this case, now this would be damaging to the host. So we don't want that. We want proper regulation of the inflammatory response. Okay, so these are the cardinal signs of inflammation. I've already alluded to this when I gave you the example of where you've had a cut. All of us have experienced inflammation, whether it's an infection, for example, like a throat infection, and you have pain on swallowing. If you examine your throat, you'll see some redness. If it's very severe, you may have some fever. So all these are signs of inflammation. What is in italics is a Latin name from which we derive these signs. So ruba being redness or the erythema that is seen. Tumor meaning a swelling, okay? So not tumor meaning cancer. Tumor basically means a swelling, but we know that most cancers present with swelling, okay? Then color meaning heat, okay? So if it's just that limited to one site, then there'll be, like if it's like an injury on the skin, if you feel it, it will be warmer than the other part of the body. If it's systemic, of course, this heat would translate to a fever. And then there'll be dolor, meaning pain. And then, so those are the four major signs that we see in acute inflammation. In chronic inflammation, because of the amount of injury or the chronicity of the process and the amount of tissue damage that occurs, and healing with fibrosis. Remember, if there's healing by fibrosis, meaning the normal cellular constituents cannot regenerate, so you get fibrous tissue instead, then if these cells were performing, like specialized cells performing a certain function, then the fibrous tissue cannot perform that function. So that's what we mean by functionless, so you get loss of function. And you'll see very many contexts in which this can occur later on. Okay, so for us, or for you guys rather, in second year, the main, or the reason why you need to know about inflammation is because of its role in combating infection, because this is the year when you're going through your microbiology. So we'll see what is the importance of the inflammatory response in getting rid of infection. So one is that, fine, we do have our resident tissue macrophages, for example, in different tissues, and our dendritic cells, for example, in the dermis, and those few cells that are there are able, remember when they take up or they encounter pathogen, they take it up, process it into peptides. Usually they'll travel to the nearest lymphoid tissue or the nearest lymph node to present that antigen to the T cells, okay? However, the vascular changes and the things that occur to cause the, especially the white blood cells to come to the site of infection is important, because it means we're delivering additional effector cells to the site so that we can get rid of the infection quickly, okay? So the importance of inflammation when there's an infection is that it's able to deliver additional effector molecules and cells to the site to augment or to increase the killing of these invading microorganisms by the frontline macrophages. So you see the macrophages are frontline, and then now they come and recruit the other more specialized or more effective cells and molecules, okay? The other thing is that, but I won't go much into detail with this, is that when we get activation of the inflammatory response, we also do get activation of the coagulation system. I don't want to go into details because you haven't covered hematology yet, but when you do your general pathology next year, you'll be able to tie all this in together. So we do get activation of the coagulation cascade. And the aim of this is to sort of form a clot. You know, activation of coagulation basically leads to formation of a clot or a plug. So this is basically to try and just wall off the site where these infectious pathogens are so that they do not spread, okay? And then, of course, if there's been infection to some extent, there'll be some tissue injury, okay? Remember, some of these microbes produce toxins and things like that that will cause damage to host cells. So the other important aspect of inflammation is to promote, once you've gotten rid of the pathogen, you want to promote repair of any injured tissue. So there are 4 main phases of inflammation. The first one is that, of course, there has to be recognition of infection or the offending agent. And here specifically, we talked about the macrophages and dendritic cells recognizing either the pathogen-associated molecular patterns, if there's an infection, or if there's been an offending agent that causes cell or tissue injury, then they recognize damage-associated molecular patterns, so pumps and dumps. Then the second thing would be, so these cells will be activated, and then their byproduct or whatever they produce would recruit inflammatory cells. So and then when these inflammatory cells come to the site, then they'll eliminate the microbe or the offending agent. And then finally, we get resolution. So everything goes back to normal. So in terms of recognition of infection, I've talked about the pumps and dumps and how do the macrophages and dendritic cells recognize them. They use their pattern recognition receptors, because remember the pumps and dumps are just sort of molecular structures that involve the cell surface of these microbes or the changes that would occur on a host cell surface, okay? So they use the pattern recognition, pattern recognition receptors to do that, and then they become activated and release pro-inflammatory cytokines and preformed mediators. So these pro-inflammatory cytokines and preformed mediators are the ones that would act on the vasculature or on the endothelial cells to cause changes that would allow for your other white blood cells to exit the vasculature. Okay, and this is shown in this picture. Okay, so what the cytokines do, they sort of, they have effects on, remember we've talked about how cytokines act. Okay, so when they're produced, they would either act on the cell that produced it, that's an autocrine fashion, or on neighboring cells, or which would be a juxtacrine mechanism, or on cells that are further away, which would be endocrine fashion. But for the cytokine to be effective, it has to bind to its cognate receptor. Okay, so these endothelial cells that line the vasculature would have some receptors onto which some of these cytokines bind. And what they do, they cause activation or upregulation of these molecules called the selectins, okay? So for example, P-selectin, E-selectin, okay? The other thing that happens, you get slowing down in the transit of these cells. So usually when the cells are flowing in blood, we say they're flowing in a laminar fashion. Usually they're at the center, whether it's white blood cells, red cells, platelets, they're at the center. They don't usually touch, they're not adjacent to the vasculature, okay? They flow at the center, but some of the mediators that are produced by the innate immune cells cause slowing down of the vasculature, which allows for the white blood cells to now come into contact with the endothelial cells, okay? So the white blood cells express molecules called integrin. So the integrin expression can also be upregulated by the cytokines and preformed mediators. So as now they come and contact the endothelial cells, you get the integrins interacting with the selectins. So they sort of attach, and this basically slows them down. So we call this adhesion. So as they are slowing down and coming to interact with the endothelial cells, we call that rolling. So they'll just flow along the endothelial cell membrane. And then when they attach, then they're actually now slowed down. And the other change that occurs is that you do get separation or widening of the endothelial gaps between the endothelial cells, which now would allow for transmigration of the neutrophils through the vasculature. And then they'll go to the site of inflammation. And what would now basically guide or attract this trafficking of the neutrophils would be chemokines, okay? Remember, chemokines cause cells to move to a certain site to where they're being produced through that chemical sort of recognition. So that is what occurs. That's how the inflammatory cells are recruited from the vasculature into the site of inflammation. So when you talk about endothelium being in an inflamed state, it just talks about the activation of the selectins and the widening of the endothelial gaps. So of course, when the neutrophils come to the site, they'll kill the offending pathogen, usually by phagocytosis, and we've gone through the whole process of phagocytosis. And we say that, we mentioned that if the phagocytosis is frustrated, or if maybe the pathogen load is too much, then instead they'll release their neutrophil extracellular traps, which involves also release of the chromatin structure that is sticky, which will sort of cause the pathogens, limit them or immobilize them because they'll stick to the chromatin. And then the enzymes and the reactive oxygen species that are produced would be the ones that cause damage. But I mentioned that these granule contents are not uniquely toxic for the microbes, okay? They'll also cause significant damage to host cells and tissues. So if the inflammatory response is able to get rid of the microbe, then you now start getting upregulation of the anti-inflammatory signals. So that you get a balance, and then you get resolution of inflammation. So that is the process of inflammation. I just want to now mention the mediators. So these are soluble diffuse molecules, which would act either locally at the site of tissue damage, or at the site of infection, or at more distant sites, okay? A distant site, for example, would be, I showed you that picture where you get some of the cytokines acting on the hypothalamus in the brain, even if the inflammation probably is like in the thigh, okay? Maybe someone has had a thigh injury or some sort of cellulitis with an infection in the thigh, okay? So these mediators are produced in response to various stimuli. So for example, they can be produced in response to microbial products, okay? For example, microbial toxins or other things that these microbes could be producing. If the cell death due to some sort of injury, whether it's a chemical injury or a physical injury, then substances released from these dead and dying cells could also induce production of these mediators. And then we also have the proteins of the complement system being mediators of inflammation. We've covered that well. And then there's the kinin and coagulation systems, which I really won't go into details so that I don't confuse you. But anytime, like for example, if you have, if the tissue injury is one that causes bleeding, like there's a cut, of course, one of the responses, yes, you'll get an inflammatory response, which will help with healing. But if there's a cut, and it's the bleeding is not controlled, even if you have acute inflammation, just your inflammatory cells being activated, if you don't control the bleeding, then what would be deleterious to the host would be the bleeding. So of course, you have to get your coagulation system being activated. The kinin system is activated by certain tissue proteins that are produced, which I won't go into details of right now. So the mediators can either be exogenous or endogenous. So the exogenous ones would be the ones would be the bacterial products and toxins. For example, endotoxin or lipopolysaccharide from your gram-negative bacteria, okay? You later come to see how, I guess in third year, endotoxin can cause a very severe inflammatory response that is systemic and actually leads to what we call endotoxic shock. For the endogenous mediators, these are the ones that are produced by the host, either by cells, so could be things like cytokines, or from plasma proteins, okay? Best example, I guess I'd give you is the complement proteins, because remember complement proteins are plasma proteins that are produced by the liver. So the cell-derived ones usually sequestered within intracellular granules. And when there's granular exocytosis, they're rapidly secreted. So a good example of this would be histamine in mast cell granules, but usually we don't see histamine in the typical acute inflammatory response. This one would cause inflammation in a hypersensitivity response, specifically a type 1 hypersensitivity response, which usually would be an allergic reaction, but it would have some effects on vasculature, on smooth muscle, and so forth. That would actually be an inflammatory response. So either they are already preformed and they're released, or once these cells are activated, the synthesis begins. So de novo synthesis. And these are actually the more important ones when we're talking about acute inflammation. So this would be things like cytokines. Remember, we talked about once your macrophages, for example, recognize the pumps and dumps, they become activated, and then you get expression or upregulation of pro-inflammatory genes. So that some of these could be genes that code for some of these cytokines. They now become activated at this phase, and then that's when you get the cytokines being produced, okay? So it's not like you have granules that already have the preformed cytokines. These ones are synthesized anew. So some of the cells that produce these cytokines or inflammatory mediators include your platelets, neutrophils, the monocytes and macrophages, mast cells, and even mesenchymal cells like endothelium, smooth muscle, fibroblasts, and epithelial cells. So the plasma-derived ones, they tend to be the plasma proteins, and we know majority of our plasma proteins are produced by the liver. Usually they present in circulation as inactive precursors, which must be activated by cleavage, okay? So proteolytic cleavage is what now leads to the active form of these proteins. For example, the complement proteins, okay? Remember, one is you get one protein being activated, okay, or being cleaved, it becomes active, and then it activates or cleaves the next one in the cascade, okay? So this table was just to show you some of the mediators of inflammation, the cell-derived and the plasma protein-derived ones, and the effects that they have. So let me not talk much about histamine. We'll talk about this in type 1 hypersensitivity. But for example, things like the cytokines, they cause local endothelial activation, for example, expression of adhesion molecules. So this would be the selectins, those are adhesion molecules. And they're called that because they allow the white blood cells to adhere to the endothelium through the integrins, okay? These same cytokines, tumor necrosis factor, interleukin-1, interleukin-6, also responsible for their endocrine action on the hypothalamus, where now they're the ones responsible for causing fever, pain, anorexia, which is loss of appetite. In severe infection, this is what I was talking about in severe gram-negative bacteria infection, where you get a lot of endotoxins being produced or being endotoxins activating your immune system, then you can get what we call endotoxic shock, which presents with hypotension. So there's basically a fall in blood pressure, like the vascular tone cannot be maintained, and that's what leads to pathology. Then you also have chemokines, which cause chemotaxis and leukocyte activation and so forth. For the plasma protein derived ones, so you know about the complement system and the complement proteins, and we always talk about the byproducts, and that is where they're important in the inflammatory response, the C3A especially, and C5A, okay? They're chemoattractant, and they also cause vasodilation, okay? I think the only reason I highlighted the kinins is because they specifically are associated with the pain that we feel whenever there's an inflammatory response, okay? But I guess this is what I would want you to know. This is a summary of the different mediators and what they do. So for example, the prostaglandins, nitric oxide, histamine cause vasodilation. Of course, with vasodilation, because you're widening the caliber of the blood vessels, this also leads to slowing down of the flow, and that is what would allow rolling of your neutrophils, okay? Then the histamine, C3A and C5A, bradykinin, leukotrienes, and so forth cause increased vascular permeability. So that's where we have the widening of the endothelial gaps that would allow the white blood cells to transmigrate. Then the molecules that cause chemotaxis, recruitment and activation of leukocytes, so specifically the cytokines, TNF, interleukin-1, let me also add interleukin-6. Everyone is talking about it in COVID-19. So chemokines, C3A and C5A, leukotriene B4 and some bacterial products. And then you have still the same cytokines being responsible for causing fever, prostaglandins and bradykinin causing pain, and then the enzymes and the reactive oxygen species from the leukocytes being the ones that cause tissue damage. Okay, so these are basically the things that we see occurring in acute inflammation, and all of them occur at the same time. Okay, I think I'll skip this. This was just to show you the interrelationship between the 4 plasma protein or mediator systems, which are triggered and how they come together. Maybe we'll come back to this. We can talk more about this when you're in 4th year. Yeah, because I think we'll meet next in immunology in year 4. You'll have already covered your general pathology. Okay, so the things with the mediators, one mediator can stimulate release of others. For example, if a macrophage produces tumor necrosis factor, this can act on endothelial cells to stimulate them to produce interleukin-1. So you sort of get things happening in a cascade fashion, just the same way you get activation of your plasma proteins in a cascade fashion. And then the secondary mediators, the ones which now are produced from the effect of the first one, may have the same action as the initial mediator. So for example, with this example, we see TNF and interleukin-1, if they act on the hypothalamus, they have the same effect, okay? But they can also have different or opposing activities. So you can either get amplification of one response or counteraction, depending on what mediators are involved. These mediators, most of them tend to be short-lived, okay? So for example, your cytokines, we know cytokines have a very short half-life, so they decay quickly. Also the arachidonic acid metabolites like the prostaglandins. I'm sure you've covered this very well in physiology and in pharmacology. They're also they can be inactivated by enzymes. So for example, for the kinins, we have other plasma proteins which inactivate them, like the kininase. Okay, they can be scavenged. So for example, the toxic or the reactive oxygen metabolites we talked about during phagocytosis can be scavenged or broken down by the antioxidants, okay? Or they can be inhibited. For example, for the complement system, we have the regulatory proteins which would inhibit them. So this is just sort of, just to highlight that there's always some sort of balance just to prevent excessive inflammation, because as much as inflammation is supposed to be protective, if you cannot control it or if it's excessive, then it ends up being the one that is responsible for causing pathology, okay? Yeah, I don't think I'll go into details of this picture. I'm sure you've covered this well in pharmacology, and you see where certain anti-inflammatory agents or medications, or you're covering it now, I don't know, you do pharmco in 2nd and 3rd year, I think, but you'll see where certain inflammatory agents are important to prevent inflammation. Okay, cytokines, I just wanted to highlight something on cytokines and their roles in inflammation. Specifically, I think I'll just need you to know about cytokines in acute inflammation. We'll cover more of cytokines in chronic inflammation when we talk about the delay-type hypersensitivity reactions. You already know about how cytokines act, either the autocrine, justacrine, or justacrine is the same as paracrine, or the endocrine effects. But the important cytokines to know are that are involved in the acute inflammatory response are tumor necrosis factor, interleukin-1 and interleukin-6, and then the chemokines, which would be the one that recruit your leukocytes. So interleukin-6, as you can see, would cause systemic effects. You know, a patient would be very sick. things about fever, anorexia, all the things I've talked about. And I'm sure you know that this is one of the sort of targeted treatments that is also instituted in patients who present with severe COVID-19. So tocilizumab, which is an antibody against the interleukin-6 receptor. So when it binds to the interleukin-6 receptor, then interleukin-6 cannot bind, okay, because it's being produced in these patients, so it cannot bind and it will not be effective, okay. I guess in fourth year, we'll talk about how the inflammatory response would lead to pathology, okay. In chronic inflammation, these are the important cytokines, I think majorly interleukin-12 and interferon gamma. I guess we'll talk about these ones when we talk about your delayed type hypersensitivity or your type 4 hypersensitivity reactions, okay? Interleukin-17 is one of the newer cytokines that was identified. Usually it's produced by a subset of T lymphocytes called the T helper 17 cells, and usually is they're involved in recruiting neutrophils and monocytes. So majorly in bacterial infections, extracellular bacterial infections, and fungal infections, okay? So what happens in severe disease is that you get these cytokines, especially the TNF, interleukin-1 and interleukin-6, being produced in very large amounts, and that is where they exert the endocrine effect, and you get basically major systemic effects that makes a patient very sick. Case in point, cytokine storm in severe COVID-19. So I mentioned that at the end of the day, once we get the offending agent being removed, you do want resolution of the inflammatory response. So there are several mechanisms that are involved in shutting down inflammation and promoting resolution and repair, okay? I won't really go into details of this right now. Maybe I'll just mention the cytokines and some of the mediators. So like the lipoxins, which are still arachidonic acid metabolites, if you go and revise that production system. This one stops the influx of neutrophils, promote the uptake of apoptotic neutrophils, and recruit additional monocytes. So what the monocytes do, they come and take up all the cellular debris that's been on the site. You know, they come to the tissue, become macrophages, and just phagocytose any damaged, dying cells, so they're removed and the tissue goes back to normal, okay? You also have secretory leukocyte protease inhibitor. So this, it's, as you can see, it's a protease inhibitor, and it's important in inactivating the proteases that are released from the neutrophil granules, okay? Importantly, you have the anti-inflammatory cytokines. So there are two major anti-inflammatory cytokines, that's interleukin-10 and transforming growth factor beta. So as the name suggests, they'll basically inhibit the effect of the pro-inflammatory ones. They'll shut down the pro-inflammatory response, maybe cause production of, you know, reverse the activation of the pro-inflammatory genes to the anti-inflammatory ones and things like that. Glucocorticoids, remember glucocorticoids are drugs, but you also have the ones that are synthesized by the body from the adrenals, okay? So usually when there's an inflammatory reaction, especially a systemic inflammatory reactions, you do get activation of your adrenals to produce their own glucocorticoids to sort of counter this reaction. And you'll see in clinical chemistry that one of the ways or one of the biomarkers we use when we're just trying to assess severity of disease or inflammation in a patient is by measuring the plasma cortisol levels, okay? And then you have some decoy receptors like cleaved extracellular domains of cytokines. So for example, you get like a soluble receptor to TNF or interleukin-1. So because it's soluble, it's not on the surface of the cell. If the cytokine binds, there'll be no effect. So it quenches that cytokine, because an effect of a cytokine can only be produced if the receptor is on the surface of a cell, because once you get engagement of the cytokine to its receptor, then you get downstream intracellular signaling to the level of the nucleus, and you get activation of a specific gene and transcription and production of a protein. So if you get soluble receptors being produced, they basically prevent the downstream action of that cytokine by neutralizing it. You also get complement inhibitors or your complement regulatory proteins, which would inhibit complement activation. Molecules that would inhibit your lipid mediators and your prostaglandins, acute phase proteins, and I've talked about the stress hormones like the corticosteroids, and you also have the catecholamines from the adrenals. So finally, as I'm winding down, just talking a bit more about acute inflammation. So we've already described all this, and we've seen how this occurs. It's a rapid host response, which serves to deliver leukocytes and plasma proteins. In the context of an infection, the important plasma protein here would be an antibody, right? Okay, to sites of infection or tissue injury. Okay, and you know the effector function of antibodies, how it helps to get rid of infection. I think I've already alluded to this. The major components being vascular dilatation. So this is just trying to show you the difference between inflamed and uninflamed vasculature. So you can see the widening or increase of the caliber of the blood vessels, both the arterioles, the capillaries, and the venules. And this is now what allows for slowing down of the blood flow. And then you get the rolling of the blood, of the white blood cells, the adhesion, and then the transmigration. So you can see usually in normal tissue, we do have a few lymphocytes and basically your resident macrophages, but usually don't get a lot of these immune cells in tissues. But in acutely inflamed tissue, we do get a lot of accumulation of your neutrophils. And this is how we are able to identify under microscopy that there's an acute inflammatory response. You see all these polymorphonuclei infiltrate, okay? Ideally, you don't, in a normal tissue, you will never have neutrophils. Neutrophils are always present in blood. If you see neutrophils in tissue, there's inflammation going on. Acute inflammation can be stimulated by infections, by tissue injury, whether it's ischemic injury, trauma, chemical injury, thermal injury, and even radiation. Foreign bodies, and of course, when these foreign bodies are from whether they're contaminated by pathogens, or you do get like foreign bodies that cannot really be gotten rid of, small particles that remain within the tissue that will trigger an inflammatory response. And then we also have the hypersensitivity reactions, which are basically exaggerated inflammatory responses to what would be really harmless antigens, okay? And these tend to be environmental antigens, things like pollen, things like latex, like things that usually would not cause harm, but they end up inducing a very exaggerated response. So those are the hypersensitivity reactions. We'll talk about them later. So I've already alluded to the vascular changes, which are basically, they happen so that you can get transmigration of your white blood cells and accumulation of plasma proteins to the site of injury or the site of infection. And we call that exudation, okay? When you get your fluid, plasma proteins, fluid, and cells coming from the vascular system into the interstitial tissue or body cavities, if there's an inflammatory process going there, we call that exudation. In situations where you have decreased colloid osmotic pressure, for example, maybe, what maintains your vascular tone or the vascular pressure would be a balance between the cardiac output and the plasma proteins. So if there are decreased plasma proteins, you'll only get your fluid leaking out. So that would be called a transudate. We'll talk more about this in chemical pathology or in clinical chemistry. I think I'll also skip this. The other thing I just wanted to highlight is the edema or the tissue swelling that we see in inflammation, and that is caused by the fluid accumulation, okay? And then pus would basically be an exudate. So I've already told you what an exudate is. If it has dead and dying neutrophils, we call it a purulent exudate. And what gives pus its color, it's because of the reactions of the myeloperoxidase. Sometimes you see it like looking green. It's just because of that, those enzymes that are found in the neutrophils, okay? So I've already talked about how the neutrophils or the leukocytes emigrate. So first they adhere, then they migrate, then they're attracted to the site of the pathogen, for example, through chemotaxis, where they also come, recognize the microbe and dead tissues, phagocytose them, and remove them. I think I already showed you this. We talked about termination of the acute inflammatory response. We've talked about short half-lives of both the cells that are involved and the mediators that are produced. Okay, I think that's the important message there. I've also alluded to the mechanisms that are now switched on to produce top signals, okay? So for example, for the arachidonic acid metabolites, instead of producing the pro-inflammatory leukotrienes, you get the lipoxins being produced. We'll see the importance of leukotrienes in the type 1 hypersensitivity reactions. We've talked about the anti-inflammatory cytokines, like tumor transforming growth factor beta and interleukin 10, okay? So finally, the outcomes of inflammation. So you get your injury, you get activation of an acute inflammatory response. If you get the injury is gotten rid of, the pathogens are gotten rid of, you get resolution. So the tissue goes back to normal. Okay, sometimes if you get very purulent response, a lot of neutrophils accumulating and producing, they're dying, and you get accumulation of these dead neutrophils with the pathogen and so forth, then that's when you get pus formation, what we call an abscess, okay? But usually once you get your more monocytes being attracted to the site, they'll come and phagocytose all this debris, okay? If it happens within a short time, the tissue can go back to normal. If it's very extensive, then you can get now fibrosis occurring. So you get collagen deposition, okay? If the acute inflammatory response doesn't get rid of the pathogen, then it progresses to chronic inflammation. And you can see the differences between the cellular infiltrate. In acute inflammation, you're getting mainly the neutrophils. In chronic inflammation, you get mononuclear cells, which would be phagocytes. So the larger cells are the phagocytes, and the small round cells are lymphocytes, okay? I mentioned chronic inflammation is really prolonged, so weeks or months. So if there's inflammation ongoing for more than 2 weeks, usually it should be chronic inflammation. And the thing is that with the inflammation, you also get attempt at tissue repair. So you get both occurring at the same time. It can either start on its own, or it can progress from acute inflammation. And we'll later come to see the importance of chronic inflammatory processes in certain diseases. In terms of infection, the prototype would be tuberculosis. Usually the immune response to TB is a chronic inflammatory response. It's also a type 4 hypersensitivity response. We'll talk about that when we go to the series on hypersensitivity. But other debilitating diseases like rheumatoid arthritis, which is an autoimmune disease, atherosclerosis, are also chronic inflammatory process, and we'll cover more of that in pathology next year. In terms of infections, usually the pathogens that would induce chronic inflammatory processes are the ones that cause persistent infection. So either they're causing intracellular infections and really evading killing. So for example, tuberculosis, as much as it causes intracellular infection and can even infect your phagocytes, it would really, it has mechanisms of preventing fusion of your phagosome and your lysosome. So it's going to remain viable within the phagocyte cytoplasm, and it can proliferate. Then I've mentioned the immune-mediated inflammatory diseases like rheumatoid arthritis and so forth. In terms of the cellular infiltrates, it's the mononuclear cells, so macrophages, lymphocytes. Sometimes you may have plasma cells, which are still of lymphoid origin, and they're also mononuclear. And then, so you have ongoing tissue destruction and ongoing attempts at healing. And healing usually would be with fibrosis. And this, I think this is my last slide. Oh, no. Yeah, probably it will be. It was just to show you now how we as pathologists are able to evaluate this in tissue. This, I think this is skeletal. No, this, I think this is cardiac muscle. So you can see the under microscopy, of course, the picture resolution is not so good, but you can see the inflammatory cells we're seeing within this tissue are mainly neutrophils. You can see the multi-lobed nature of the nuclei compared to this other tissue, which is also muscle. If you can identify it from your histology, as you can see the cells here, basically mononuclear cells. They just have one round nucleus. So very evident, this is acute inflammation and this is chronic inflammation. I think I'll skip the granulomatous inflammation. We'll talk about this later. I sort of bridged you to pathology, but I guess because that's my bias. Okay, so do we have any questions? I think I saw a couple of comments on the chat. Let me see. Someone is asking from the gut, for the gut. Okay, what causes the pain? I mentioned kinin. Okay, so it's the effect of the kinins, like bradykinin. You can go and read up more on that. Or maybe you don't have, you can if you're interested in, but you'll cover that in pathology next year. Someone is asking for the gut. There's continuous exposure to gut microbiome antigens, yet there's no inflammatory response component of innate immunity. These antigens are still used to train naive cells of the adaptive immune system. What is the cause and reason for this dissonance? Tolerance. I don't know. Have you had your lecture on tolerance? SK, whoever asked that question. Have you guys had your lecture on tolerance, immune tolerance? So this guy is basically asking, I think it was a direct message, why we don't have an inflammatory response to the gut microbiota. So I think you'll, maybe you'll understand this better when you have your lecture on tolerance. Okay, you haven't had it yet. So tolerance is basically, I'll just tell you what it is. It's a state of unresponsiveness to an antigen. Okay, so you have an antigen that ideally should cause an immune response, but the immune response does not respond to it. And there are several mechanisms by which this happens. So when you have your lecture on tolerance, you'll get to understand why we don't respond to all antigens we are exposed to, and why tolerance is important, and what can happen if there is no tolerance or there's breakdown in tolerance. So in the gut, we have what we call oral tolerance, and that's why a normal person does not have an immune reaction, not only against the bacteria in the gut, but also against like food, because the food we eat is a foreign protein, okay? So ideally, a competent immune system should mount a response against it, but we don't because it's not harmless to us. Mediators released from damaged or activated cells. I don't know what that was. In the autoimmune disorders, such as GBS and celiac, is the genesis of problem activation of macrophages by non-harmful pumps. So this will come back, we'll understand it better in tolerance. So same guy is asking about, or lady, what happens in autoimmune disorders. So I think once we have the lecture on tolerance, then we'll get to understand this further. And I just want to highlight that the autoimmune response is usually, you have to have, for that to be a lasting autoimmune response, you do need the adaptive immune system to be the one that is activated against the self antigen. Okay, because the adaptive immune response is the one that will be sustained, it's the one that will have memory. But once we have the lecture on tolerance, and I think we'll have another one on basic autoimmunity, you'll understand this better. Are there any other questions or comments?
Okay. I don't think there are any other questions, just to thank you for the lecture.
All right, you're welcome. Have a good day.
Same to you.